Thank you, Diana. Lovely introduction. So it's a pleasure to be here. Thank you all for coming on a weekday evening. So I will basically continue where Diana left off with. So she summarized for you who should be tested, what the testing process is, the pre-counseling, the post-counseling, and once our patients receive the results, then we further discuss what it means for them, for the families, and what risk management options apply to our patients. Before we go into that, I just want to put the positive results into perspective in terms of breast cancer risk. So this chart gives you an idea about the risk of breast cancer when you have a BRCA mutation versus all the other, at this point, known risk factors, and there might be many others, but the ones we can quantify. So, for example, as Diana pointed out, individuals with the BRCA1 or 2 mutation have a up to 80% risk of breast cancer. So that's a tenfold increased risk compared to normal population. The really closest thing to that is a fourfold increased risk in individuals who have what we call benign or pre-malignant breast lesions, so not cancer, not ductal carcinomas, but pre-cancer lesions such as atypical cells. So that increases risk by fourfold. Then we have all of the other risk factors: estrogen use, lack of exercise, maybe weight gain postmenopausally, early menarche, having no children or children after age 30 or 35. So they all increase risk, but not more than double. But I put this up here just to give you a perspective that individuals with the mutation really have a very increased risk. And that's for breast cancer, and as Diana pointed out, also up to 45% risk of ovarian cancer. But luckily, only about 10 to 15% of cancers are caused by hereditary factors. So we are still dealing with the more smaller portion of the breast cancers. Here is a little bit the breakdown of the risks by age. So I had just mentioned the lifetime risk by age 70 is 80%. So that's about a 8 to 10-fold increased risk, increased risk compared to the population. But very importantly for us, we see also a lot of patients who are young. So breast cancer incidence in young women is actually very low. And if we have a patient or a high-risk individual with the mutation who's age 35, her breast cancer risk is actually not only 10 times higher, but actually more than that, 20, 40 times higher, because compared to the average population, because of the average population risk is so low in younger women, relatively speaking, with the mutation, the risk is actually highest when you're younger. And that is important because when we talk about risk management options from screening to more aggressive, if we have a 71-year-old woman with the BRCA mutation versus a 39-year-old, the choices they make to prevent cancer might be different, because most probably the 71-year-old will not develop it anymore, since she kind of most probably outlived her risk, whereas the 39-year-old is really at increased risk. Diana pointed this out. Important for us is also the knowledge that contralateral breast cancer risk is increased. And I will tell you in a minute why it's very important for us that individuals or our patients with a mutation who have breast cancer on one side, and even though if it's stage 1 or stage 2, very early, curable, the risk of developing a second one in the opposite breast is much higher than the average population. And we also discussed the increased risk of ovarian, but I will not go into that at this point again. So when we discuss the results with our patients, the implications of that and what we tell our patients depends really on if they have the disease or not. So I broke it down into two scenarios. One where we disclose the result to an unaffected person, so let's say a young, healthy woman who does not have cancer, we call them unaffected. And the other scenario is when we disclose the results to an affected person. And again, remember, we love to start testing the affected person first in the family. So the person who developed cancer at the youngest age or breast cancer should ideally undergo testing. So for the unaffected person, the person who has the, let's say, BRCA1 mutation, who doesn't have breast cancer yet, we discuss surveillance, so that means screening. I'll talk about that a little bit. We discuss prevention with a drug. It's called chemoprevention, but a lot of us don't like that word because it has nothing to do with chemotherapy, actually. It just means chemical intervention with a drug to reduce the risk. So I like to call it drug prevention or prevention with a drug. Then we also discuss preventive surgeries or prophylactic surgeries that include mastectomies and also oophorectomies because of the ovarian cancer risk. So in terms of screening, I think we now have pretty good data to recommend, and we have implemented that, adding MRI, breast MRI screening to yearly mammograms. These guidelines came out in 2007, and the reason I'm pointing this out is we actually at MD Anderson started doing MRI screening after fighting with the insurances and making phone calls and justifying. Before that, I think when we started our high-risk clinics in 2002 and 2003, we were actually doing already MRIs in our patients with BRCA mutations, but now it's more official, and the whole nation adopted it. So we do MRI screening for individuals in addition to mammogram, so we don't skip the mammogram or forget about it, for individuals with the BRCA mutation and also some other mutations. And we could, if you're interested, discuss a little bit during our discussion session. Individuals who have mutations in the P53 gene, PTEN, those individuals have also higher risk for breast cancer, up more than 50%. We also recommend MRI screening if we do not know the mutation status of a person whose first-degree relatives tested positive. If you will remember that cartoon Diana showed, first-degree relatives have a 50% risk of carrying a mutation. So they're assumed to be positive, and MRI is recommended until it's ruled out, and they decide testing it until it's ruled out. The other category, not easy to define, is when we calculate based on available models, and they are not ideal, breast cancer risk to be more than 20% lifelong. So there are a number of patients we have in our clinics where there's a very significant family history. We do the testing, but there's no BRCA mutation. However, there's something going on because there are multiple early onset breast cancers in the family. It's most probably not due to this gene, the BRCA gene, but maybe something else. And we are doing a lot of research trying to figure out why they have it. So these patients actually, after careful evaluation of their family tree and running their risk models, could qualify, if they hit the 20% lifelong risk, to do MRIs also. And again, I want to point out, this calculation is a little bit difficult, and I think that's where specialized breast risk assessment clinics are really very important, because you can hit that risk with some models that you shouldn't use, and then you can artificially increase your risk and get unnecessary MRIs. Or sometimes, if you don't know which models to use, you can actually decrease or underestimate the risk and then not do MRIs, whereas it's actually indicated. So this is a little bit difficult area, and we are all working in refining the models. So the second thing we discuss with our patients, besides screening, is prevention with a drug. So you all most probably are familiar with the agents that block estrogen, because we use it for treatment of breast cancer for estrogen receptor positive breast cancer. Tamoxifen has been for a very long time a gold standard treatment for pre- and postmenopausal women with breast cancer that have estrogen-driven disease. And then now we have the newer drugs, the aromatase inhibitors, that basically do the same thing. They prevent the production of estrogen and, again, deplete it in the body so that potential tumor cells are not fed by estrogen. However, the aromatase inhibitors, such as Arimidex, are only indicated in postmenopausal women. And again, that's only for treatment. Tamoxifen, though, made it up to the level and was studied as a prevention agent in high-risk women and was shown to reduce breast cancer risk by 50% in high-risk individuals. However, despite this rather good-looking risk reduction percentage, the acceptance is very low. Nationwide studies have shown that less than 30% of high-risk women actually say yes to tamoxifen. More than 90% say yes when it went to tamoxifen when it's used for treatment of breast cancer. But in a otherwise healthy individual, it appears it's not very acceptable because of the side effects. So increased risk of endometrial cancer, thromboembolic events, obviously menopausal symptoms because we are blocking estrogen, muscle aches and pains, fluid retention, hair thinning has been reported, even some cognitive function declining has been reported as well. Important for us and for our high-risk individuals is that because it blocks estrogen, well, we also have the other part of breast cancer, right, the one that is not estrogen-driven. So tamoxifen does not reduce the risk of estrogen non-driven or what we call estrogen-negative breast cancer. So it's not effective in that population. And we also know, based on our own data as well as other studies, that about 70% of BRCA1 mutation-related breast cancers are estrogen receptor negative. So most probably, tamoxifen is actually not going to be effective in our BRCA, especially 1 mutation carriers, maybe BRCA2 carriers, and there's not a large prospective study. So this is all extrapolation data from other studies we have. So in terms of large studies, where we are at this point, I mean, I just gave you this one drug, and I didn't give it as an example because we only have this one drug, so there are no others at this point. The raloxifene is a cousin drug of tamoxifen that has been studied but is a little bit less effective than tamoxifen and has not been studied in BRCA mutation carriers. But obviously research is going on, so we are working on some other drugs, and there are some large studies going on looking at the aromatase inhibitors in a high-risk population around the world, actually. The IBIS study is run in the UK. There's an Italian study. The NCIC study is in Canada. And then the NSABP is running another study in high-risk women who have some pre-malignant lesions. There would have been a large prospective third prevention study in the US that then got canceled, and it's not going to happen. Now, the issue with these agents are that all of these only prevent the estrogen receptor-driven breast cancer because they all block the estrogen synthesis. So and all of these agents are only indicated in postmenopausal women. So we don't have anything to prevent ER-negative premenopausal breast cancer risk. So therefore, we and many others, I think, around the nation are trying to investigate other potential preventive drugs that are safer so that not only less than 30%, but actually more than 90% of the women are willing to take it. We also need to prevent ER-negative breast cancer. And some of the interesting agents that are being considered now, and they are being investigated in smaller studies, and we are doing it also, is, for example, metformin that is actually used to treat diabetes, but it appears that there's a big mechanistic rationale behind using this for breast cancer prevention. Curcumin or turmeric has been shown in many early studies to stop the cancer initiation or progression process. Interesting, fish oil has a lot of rationale, so some studies are being planned. We had done a study with green tea. It comes in capsules also, the active ingredients, and other natural compounds. So the idea is to find something that everybody can use and that will prevent all types of subtypes of breast cancer. So, and the last option we discussed with our patients, so besides screening and chemo prevention, and I think this is my last slide, is discussing preventive surgeries. Now, this is a very sensitive issue. Preventive surgeries are very effective because they reduce the risk of cancer by more than 95%, and that has been shown in prospective trials. However, it is also a very aggressive approach. I can tell you that when we look at our population, I think after a lot of discussions and going back and forth, and whatever our patients think that is the best for them, I would say more than 80 to 90% of our high-risk women undergo oophorectomies because ovarian screening and treatment of cancer is very difficult. A little bit more than 50% undergo bilateral mastectomies, and the rest choose to do very careful screening. Now, I always get this question, so what is better, MRIs or surgery? They are not comparable because you can do MRIs every week. It doesn't prevent cancer from happening. You might pick it up early, but maybe not. The only way to really prevent it is to remove the tissue at risk, and that would be the preventive mastectomy. However, MRI is very sensitive, and it can catch the disease very early. In fact, a very recent study we did showed actually that in our patients we diagnosed recently with BRCA mutations, out of the 11, 10 cancers were picked up at a very early stage without spreading to the lymph nodes with the MRI. So it's very useful for patients who don't want to do surgeries. Oophorectomy is not only offered to reduce ovarian cancer risk, but if it's done in the premenopausal setting, it has been also shown to reduce actually breast cancer risk. So when patients do oophorectomies, they get a double benefit in terms of ovarian prevention and also breast prevention. So these are the options we discuss with our patients, from screening to prevention with a drug to preventive surgeries. And I think this was my last slide for the unaffected individuals. So for the affected, just one summary slide. In the past, we thought, well, why should we test an affected person? She already developed cancer. The only benefit would be we would identify a mutation and then we would test the unaffected individuals. But now actually we feel very good, and I think our patients can really support that idea, that it has become a very important part of the initial assessment in breast cancer care and treatment. As you know, as an institution, we function as a multidisciplinary team. So we have our surgeons, medical oncologists, radiation oncologists, pathologists, radiologists, all looking at things together and planning a long roadmap for the treatment, because we all are going to be involved, and it's best to know everything from the beginning and then chip in whenever we are needed, rather than not knowing and then meeting our patients later. So genetics and genetic evaluation and testing plays a very important role because, for example, as I had mentioned, and I'm now coming back to that, if we have a young patient with a stage 1 breast cancer on one side and she undergoes a segmental mastectomy, she'll have radiation. And then if we do the testing years later and it's BRCA positive, then we tell our patient, well, your contralateral breast cancer risk is high and your remaining breast tissue on the affected side is there also, so the risk is there. And then the question is, now she needs to go back and do double mastectomies, and the reconstruction might be a little bit difficult. So a lot of our patients now, and this is happening recently because in the past the testing wasn't available, but now a lot of our patients and also our surgeons want to know at the beginning, because if there's a mutation, they might want to do the double mastectomies and reconstruction at the same time. Again, it's a personal choice, but at least we can give that option. The other benefit is if our younger patients, premenopausal patients, undergo oophorectomy, so have their ovaries removed, they become postmenopausal, obviously. But if they become that, then they can actually use the aromatase inhibitors for their breast cancer treatment. We are not doing oophorectomies so that our patients can use the AIs. But if for a medical reason oophorectomy is done, then they become automatically a candidate to use an AI instead of a tamoxifen. And we are very excited about this third reason why it has treatment implications. For the first time ever, we have what we call smart drug, targeted agent, that targets BRCA-related cancers, breast and ovarian cancer. And one of these agents that really made it up in the I think, testing phases up to phase 3 trials is the PARP inhibitors, and there are some oral forms. They have been shown to be very effective in these mutation carriers. And finally, again, identifying a mutation in the affected person really helps us to know what's going on in the family, and then do predictive testing in all of the unaffected individuals that we go over during our counseling session. We even have pre-printed or prepared family letters that we can give to our patients to take home and to distribute without being very specific, but at least helping our patients alert their family members about the mutation in the family.